Hello, everyone. My name is Christina Saldana. I'm a PA in Winston-Salem, North Carolina, and the owner of Camel City Women's Wellness. My practice is a primary care practice that focuses on integrative women's health from menarche all the way through the menopausal transition. I deal with a lot of women who are struggling with hormonal imbalances, PCOS, PMDD, perimenopause, trying to figure out where they're at in their reproductive life and how to make themselves feel well, really from inside out. So I have two cases to share with you all today. Let's get into it. All right, so this is patient one. She's a 46-year-old female, G4P3, has three children, had a spontaneous miscarriage for her fourth pregnancy. She's otherwise fairly healthy. Her past medical history is pretty much unremarkable. She's got no hypertension, no diabetes, no blood sugar irregularities, no lung disease, kidney disease. Overall, fairly healthy, no clotting disorders, no bleeding abnormalities. But she is struggling currently with menorrhagia, for which she has a levonorgestrel IUD in place. Her BMI is 23. Her diet is mostly vegetarian, and has tried intermittent fasting in the past and actually includes fasting as part of her religious repertoire, along with meditation and yoga. So she's a pretty healthy person, physically, mentally, spiritually. She takes great pride in taking care of herself. And she's really confused why all of a sudden she's kind of feeling the symptoms that she describes to me at her first visit. So her chief complaint is really this menorrhagia, and we'll get into some of the other symptoms she's also experiencing upon that first initial evaluation. She also tells me that she's having some mid-cycle spotting, and her menses is lasting 8 or more days, which we know as medical professionals that is abnormal. Her gynecologist told her that the bleeding is to be expected as normal for this time in her life at 46 years old, and to keep the IUD in place, and that will be it. So when we kind of get into her evaluation, not only is she having this abnormal uterine bleeding, it's lasting more than 8 days when she's having a menstrual cycle. She's also having mid-cycle spotting. She's also having hot flashes, night sweats that are interrupting her sleep. She's describing irritability and anxiety, which are pretty new for her. Like I said previously, she's really in touch with meditation and yoga, and it typically can manage uncomfortable feelings, but these types of irritability and anxieties that she's describing is new and kind of uncharacteristic for her. She's had a weight gain of 15 pounds over the last year. She's also having some vaginal dryness, which is causing painful sex, and vaginal itching, which was misdiagnosed as lichen sclerosis. So not only having this abnormal bleeding, but also having a lot of constitutional symptoms, some of which are really abnormal for her, such as the irritability and anxiety, and then having night sweats, which is interrupting her sleep, which is feeding the cycle of anxiety and irritability and weight gain as well. So when I first met with her, decided we would start with some blood work labs. She had not had labs done within the last year, and then also start tracking hormones with Mira to understand what her estrogen is looking like. Just based on her age and her symptoms alone, I was already under the impression that she was very likely perimenopausal, right? And so I don't need labs or even Mira to tell me that she is perimenopausal, but rather I want to help her and help myself understand what is her hormonal pattern looking like, because number one, that can help inform us what to do, and number two, that is extremely affirming for the patient. So once we did our initial workup prior to Mira tracking, I wanted to make note that she did have a prior endometrial biopsy, which is the appropriate course of action for working up anybody with abnormal uterine bleeding, and it showed proliferative endometrium. Her prior transvaginal ultrasound showed that her IUD was correctly in place. They did not comment on the endometrial stripe in that ultrasound, but they did notice that there was a fundal fibroid that measured about 1.5 centimeters. I repeated the ultrasound. It showed a simple cyst on the left ovary, which is not alarming at all. It showed she had a little bit of a slightly thickened endometrium with an endometrial stripe of 8 millimeters. showed that the IUD was in fact in the correct place, and that fundal fibroid had grown just slightly from the year prior, which is what we sometimes see with fibroids in perimenopause. So the blood work that I collected it a week before Mira. Pretty much everything looked okay. Iron, B12, folate, D3, thyroid, blood counts, her metabolic panel, blood sugar, all of that was all within optimal range. Her testosterone looked normal and to be expected for a female. Her sex hormone binding globulin was a little on the high side. If I recall correctly, this patient had previously in years past been on oral birth control pills, which is maybe likely the reason for this higher than normal sex hormone binding globulin because her liver enzymes were normal and her thyroid panel was normal. And within a thyroid panel, I checked TSH, free T3, free T4, reverse T3, and thyroid antibodies. Her estradiol was a little bit surprising to me. It was 946 in that one instance that we checked it. Her high sensitivity CRP was within normal range, which is something that I use to understand cardiovascular risk. And then I also tested saliva cortisol, a 4-point cortisol curve, and that was all normal, suggesting she had appropriate adrenal function. So immediately before we started testing with Mira, and in fact, in that time frame that we collected that high estradiol of 946, patient had had 14 days of menstrual bleeding. So we were waiting to start Mira on day 6 as it's instructed in the package insert. But we were having a hard time discerning when that day 6 was because she was bleeding, she was just having a lot of bleeding. I suggested that she had a loop cycle and we captured that, which is why she had those 14 days of bleeding and also that really high estradiol level. And then on cycle day 6 to 9, she was having increased irritability and insomnia. So I went ahead kind of right off the bat, and we'll see this in her chart in the next slide. I went ahead and started her on oral micronized progesterone, one to help with the irritability and the insomnia that she was describing. As we know, when we take oral micronized progesterone orally, it gets metabolized into lots of different metabolites, and one of those metabolites, allopregnanolone, does bind to GABA receptors and can have a calming effect and help with sleep and anxiety or irritability. So for that, and also to help balance out that estradiol level of 946. And again, that is just one snapshot in time, that blood level. So I'm not basing too much of my clinical decision making just based off of that level, knowing that in a perimenopausal woman, this is bouncing around, which is what I like to use Mira for because it helps us understand the full picture. So if we look at that, this is her chart. So the gray is E3G, or the metabolite of estrogen. That is bouncing around and fluctuating a lot. So normally you'd get that follicular, slow follicular rise and peak in the follicular phase right before an LH surge, and then it would we would expect it to fall and then maybe have a smaller peak in the luteal phase. And what we're seeing for her estrogen or her E3G is it's just bouncing around a lot. You'll see that the progesterone was low at the beginning and then it went all the way up and it's maxed out there at 30. And that is because I am giving her oral micronized progesterone, which is metabolating and it's maxing out on this Mira data. So I'm not too worried or concerned or basing any of my clinical decision off of that. Again, I started that really early on prior to collecting a lot of Mira data because the patient was having bothersome symptoms and there's no reason to delay treatment for the sake of collecting some data, which is what I tell my patients, right? Like if their symptoms are not so bothersome that we can do collect data collection before initiating hormone therapy or interventions, then we do. And if not, we just make do with what we have and we make the patient feel more comfortable. So that's what you see there for the PDG levels. They're maxed out because of the progesterone supplementation. And again, honing in here on these E3G levels is they're just bouncing around a lot, right? They're not demonstrating that classical pattern that we would normally see with E3G or expected to see E3G in maybe say a 20 or a 30-year-old woman. Also, just of note, her FSH is not bouncing around a lot, but it does peak fairly high there in maybe what would have been her luteal phase. So that's just something to make note of. That does start to bounce around a lot during perimenopause and levels can be on the high side. So she was feeling better. She had improved sleep with the progesterone. However, she was still having night sweats. She was having hot flashes during the day. She was still reporting some irritability and anxiety, which the progesterone did take care of initially. And then it just seemed to come back or didn't seem to be ameliorated over the long term. And then she was also having some depressive symptoms. And so I went ahead and started her on an estradiol patch. And you might say, well, why did you do that when her levels are bouncing around and they're high and then they're low? And then that one blood test was 946. But what this patch is doing is it's keeping her off the bottom. It's not stopping the fluctuations of her hormones. It's not giving her too much. All of that fluctuation is all from ovarian tissue. Her ovaries doing what they're supposed to be doing, what they think they need to be doing during perimenopausal transition. So, a lot of these symptoms of hot flashes, irritability, anxiety, depression, mood symptoms, a lot of those are due to those fluctuating levels, not necessarily them being too high or too low. Now, in postmenopause, when they are not fluctuating anymore and those hormone levels are very low, then symptoms can come about because they are too low for a prolonged period of time, and now you're in a state of estradiol deprivation. But during perimenopause, a lot of these symptoms are because of these fluctuating levels. So that patch is just merely there to keep her off of the bottom. Even a maximum dose of a patch is not going to exceed anything that your ovaries would have been producing just in their normal state. So we went ahead and started that after we were able to demonstrate that she's having a wildly fluctuating estradiol level or an E3G level. We continued the progesterone. I added some magnesium glycinate at night, 240 milligrams. I prefer glycinate because that can help also bind to GABA receptors and have that calming effect. I had her go back to an intermittent fasting protocol because she reported that she felt best when she was doing that. I asked her to increase strength training up to 4 days per week. She had not been doing any prior. She was doing, her yoga practice and walking, but I wanted her to add in some strength training. Now that we were able to really demonstrate, yes, you are here in this perimenopausal period. We know this because of your symptoms that you've reporting, your age, your bleeding pattern, and now these fluctuating estrogen levels we were able to demonstrate with Mira. The patient honestly didn't want to keep charting after we started using the estradiol patch. And so we didn't continue to follow up. We just used it for this short amount of time, knowing that we can always go back to this in the future if her symptom or her clinical picture changes and we kind of want to get an understanding of what's going on. So, in summary, 46-year-old perimenopausal women, she had lots of symptoms, both physical symptoms as well as emotional symptoms, including hot flashes, night sweats, insomnia, anxiety, irritability, depression, weight gain, and abnormal uterine bleeding. And she came to me to understand what her hormones were doing. Serum testing revealed a very high estrogen level, I should say estradiol level. But again, this is one snapshot in time. So I was able to use Mira to help both me and her understand what her underlying hormone pattern looked like. And one, that helped to inform what to do next. But two, it also was very affirming of her experience and the symptoms that she was having. So using this, we were able to first start with adding in some progesterone support, which we decided to do kind of quickly after, right? And then we added in some estradiol to help further optimize her perimenopausal care. And again, have that patch be there to help keep her off the bottom of those fluctuating levels. So we were really grateful for Mira to be able to demonstrate these wildly varied estrogen fluctuations. And then when I saw her back at her 3-month follow-up, she was doing very well. An oral micronized progesterone at 100 milligrams at night. Her estradiol patch was dosed at 0.05 milligrams twice per week, which is a middle of the ground dose, which is kind of where I always start. And then she still has her levonorgestrel IUD in place to help with bleeding, and I advised her to keep it there just because she is having bleeding. And these perimenopausal doses of hormone therapy are not necessarily going to help with the bleeding, and so the IUD is good to keep in place for that. And then at this point, her symptoms are optimally managed.